Chris, thanks, and thanks for having me over. It's wonderful to be in the hallowed Stanford atmosphere and speak to you all. So it's really a privilege. I bring you greetings from Mumbai. For those of you all who have not been to India, Mumbai is on the west coast of India. Uh, this is the largest cancer hospital called the Tata Memorial Hospital. Started in the early 40s, a philanthropic gesture to the nation by a big industrial house called the Tata Group. Subsequently, we are funded by the federal government. So for the last 40 odd years, we are under the central government, and that's the way we work. But our numbers are tremendous. We see close to 45,000 new cancer patients every year. And as you all would know, 1/3 of all cancers in India are head and neck related. So this is last year's hospital registry data of 2014. We see close to 9,000 new cancer patients every year. We do about 3,000 major surgeries, and 40% of our work is oral cavity. But just given the sheer volume of numbers, whatever we do, whether it's salivary glands or thyroid, you get a fair deal of everything, even though it's a smaller percentage compared to oral cavity. So when Chris asked me to speak, last week I was at ASCO, and I was surprised when I sent the abstract in that it was chosen as a plenary, because ASCO is predominantly medical oncology run, and this is a pure surgical trial. But years back when I started the trial, Randy told me that when you're complete, send it to ASCO. So I think I need to give him some credit. So I just sent this abstract in. 2 months later, I got a little thing in the mail that is being chosen for the plenary. Basically, it is elective versus therapeutic neck dissection in the treatment of early node-negative squamous cell carcinoma of the oral cavity. And that's what I'm going to share with you all in the next 15-20 minutes. The article was also simultaneously accepted and published at the New England Journal of Medicine. So this data is out in public domain. There's more data than what we've put into the main paper because the NEJM has a policy of having what is known as supplementary files. So people ask us, is your cancer HPV related? What happened to the remaining these patients? What are the complications of surgery? That's all in the supplementary file. So if I don't cover it today, you have a chance to go and look at that data outside. So I've got no disclosures to make for this presentation. Contrary to popular belief, oral cancer is a global problem. It's not a problem only in our part of the world in Southeast Asia. And as you can see from recent GloboCan data, it's important in the developed world as well, America and Australia. Wherever there is a high incidence of tobacco and alcohol consumption, you will see oral cavity cancers. Now, the management of early oral cavity cancers is predominantly surgical. The primary is excised, usually through a per-oral route. And it's as simple as this, illustrated in this picture. Now, it's important for us to understand that these kind of patients are treated not only by the oncologist, but by the general ENTs out in community practice. They are treated by the max guys, and they are also treated by the general surgeons. So this is what people do, excise the primary, which is as simple as that. Controversy surrounds the management of the neck. And as we know, there are two schools of thought. The wait and watch group that follow patients on regular surveillance and do a therapeutic neck dissection should the patient get a nodal relapse. And they cite in favor of their approach that there is no conclusive evidence of survival disadvantage in the literature. And any additional surgical procedure would be associated with significant morbidities. Most importantly, shoulder dysfunction. And this is usually not required in up to 70% of patients who remain true negative. The other school of thought do the elective neck dissection, and they cite better control and survival. And they say that it's a single stage procedure. Now they were, at the time of starting of our trial, if you review the literature, and this is from the US, a random survey of 763 ENT surgeons to determine the variability of management of the N0 neck. 13% observed, 66% did the elective neck dissection, 19% gave radiotherapy to the neck. So obviously there was gross variability in practice. And I wonder whether the higher percentage operated because they could bill twice, or did they really operate because of conviction that they were doing better? I sincerely believe maybe half of them operated because it's a bigger procedure and they could bill twice. And if you read this interesting paper, the younger guys operated more than the older guys, so it was really not scientifically done. Here is data from Europe, Germany. 50 hospitals surveyed, 39 responses, no uniform therapeutic concept for treatment of cervical nodes in the N0 neck. So the debate is going on. This was the time when we decided to start our trial. We looked at our data, retrospective, 359 patients, 200 observed, 159 operated, 89 supraomohyoid, 70 modified neck dissection. It used to be called a supraomohyoid in those days. And the results were such, both arms were equally balanced for all factors, T-stage, grade, PNI, thickness, and cut margins. Recurrences were much more as is expected in the observed group. Nearly 50% of them developed nodes as opposed to those that were operated in the elective neck dissection. But look at the bottom line, overall survival, statistically not significant at all. So even in the largest retrospective study, 359 patients, we didn't see a difference in survival. We reviewed the literature as to what's happening out there in the literature. Vandenbroek study from Gustave Roussy in France started recruiting in 1966. So we're in 2015, so this has been more than 5 years. There were a lot of studies, prospective, retrospective, and even a meta-analysis, all with conflicting results. So really not significant, not significant, not significant for disease-specific survival. And as you can see, the debate continued as recently as 2012 to 2015. And this is from the Western world. One is from the Netherlands and one is from the US. You can see there's a variability. Some people do more wait and watch and some do more elective neck dissection. So there was a state of clinical equipoise in our specialty and we needed to answer it. And we made a humble attempt at answering this through a randomized controlled trial of elective neck dissection versus the wait and watch policy, followed by a therapeutic neck dissection in those that developed a nodal relapse. So basically, what was our trial design? All patients with early node-negative squamous carcinoma were randomized to either an elective neck dissection or a wait and watch with therapeutic neck dissection after the primary was excised. There was a second randomization for follow-up where patients were randomized to physical examination and ultrasonography to establish whether ultrasonography had any role in the follow-up or in the early detection of patients who relapsed in the neck. But today, and what we presented at ASCO, was the first part of the study, elective neck dissection versus wait and watch, followed by a therapeutic neck dissection. The trial started accruing in Jan of 2014 and ran till June of 2014. At that time, the Data and Safety Monitoring Committee of the trial asked us to do an interim analysis. We had randomized 596 patients to that time. 500 patients with a minimum follow of 9 months forms the basis of the data that I'm going to share with you. And they did this predominantly on the observed differences in depth between the two arms. And that's why we were asked to do an interim analysis. What was our initial statistical consideration? Assuming a baseline survival of 60% in the wait and watch arm, improvement by 10% with elective neck dissection. It was powered at 80% with an alpha error of 0.05. The calculated sample size was 710. So we were aiming to go to 710 when we were stopped at 596. So the statistical analysis now on the 500 that have completed 9 months of follow-up, and the reason we took this 9 months was all patients would have completed active treatment, plus those in the wait and watch arm had the highest likelihood of relapsing in the neck. So that's the reason why. The others were still on active treatment and it made no sense taking them on the trial. So data was analyzed on intention to treat with the data cutoff of June 2014. Now those of you all who are familiar with statistics, when you do an interim analysis, you need to do what is known as an alpha spending function. And the alpha spending function that was adopted was the O'Brien-Fleming alpha spending function test. So using a two-sided assumption, we had already done the first interim analysis in 2012 on publication of a meta-analysis that suggested better disease-specific survival. At that time, 248 patients were analyzed. There was no significant difference and the trial was continued. So the nominal alpha allocated to that was 0.005. For this current analysis, the nominal alpha allocated was 0.027 and 0.039 was kept for the final analysis whenever the trial closed after the last patient completed adequate follow-up. So the trial schema, 1,281 patients were screened, 596 patients were randomized based on 4 stratification factors of site, stage, gender, and preoperative ultrasound. We have analyzed 500. 4 of these 500 were excluded for various causes, and the analysis was on 243 in the elective neck dissection arm and 253 in the wait and watch arm. Trial endpoints. The primary endpoint was overall survival and the secondary endpoint was disease-free survival. What were the eligibility criteria? Histologically proven, clinical T1, T2, N0 oral cavity, amenable to per oral excision. Exclusion criteria were lesions of the upper alveolus and palate and those with significant pre-malignant conditions. So patients on the trial protocol had a per oral excision of the primary tumor, randomized to END wait and watch. END arm had a selective neck dissection levels 1 to 3. If nodes were positive, either operatively we suspected or sent on frozen section, they underwent a modified neck dissection. All patients in the wait and watch arm were followed. If they developed a node, they had a therapeutic neck dissection, which was a modified clearing 1 through 5. All patients got adjuvant radiotherapy when indicated for either primary or nodal indications. Now let's look at the baseline characteristics. Both groups were equally balanced for all stratification factors, namely site, T-stage, gender, and baseline ultrasonography. You must make this I didn't say at ASCO, but I'm telling you, you must know that the majority of patients were tongue cancers, despite buccal being pretty common in our part of the country. And the reason is, buccal cancers generally may not be amenable to per oral excision, particularly when they are close to either the upper or the lower alveolus. And you do a marginal mandible and then you have to put in a radial forearm flap, or you're doing fancy reconstruction, and then once you open the cheek flap, you're going to operate. So this is predominantly a tongue cancer database. Look at factors known to affect prognosis in this group of patients. Grade, LVE or PNI, depth of invasion and adjuvant RT, and you can again see that both arms are equally balanced. The median depth of invasion of our patients in both arms was 6 millimeters. Look at the follow-up protocol. Since we had a second randomization, both arms were equally balanced for the follow-up protocol, whether it was to physical or clinical examination or physical examination and ultrasonography. The median follow-up of the study population was 39 months, which varied from 9 to 121 months in surviving patients. So we come to the meat of the presentation, primary endpoint, overall survival. There were 50 deaths in the END arm and 79 in the therapeutic neck dissection arm, translating into a 12.5% benefit in survival from 80 to 67.5 with a hazard ratio of 0.64, 95% confidence interval of 0.45 to 0.92, which was statistically significant for the alpha allocation for this second interim analysis. We did a post hoc subset analysis across all stratification factors and factors known to affect outcome in this group of patients. And as you can see, the majority of factors, the intervention arm of elective neck dissection was statistically significant in favor of the END. We look at disease-free survival. There were 81 events in the elective neck dissection arm and 146 in the therapeutic neck dissection arm, translating to a 23.5% difference in DFS with a hazard ratio of 0.45, 95% confidence interval of 0.34 to 0.59. Again, statistically very, very significant for this group of patients. As can be seen, the majority of recurrences in the wait and watch arm were neck nodal recurrences as opposed to those in the elective neck dissection arm. In the elective neck dissection arm, non-nodal recurrences were more common than nodal recurrences, and this is to be expected when you have operated the elective neck dissection arm. Let's look at the features of nodal disease. 72 of 243 patients in the END arm, nearly 30%, were occult node positive on histopathology. 114 of 253 in the therapeutic neck dissection arm, that is 45%, relapsed in the neck. If you look, the therapeutic neck dissection arm had a higher percentage of N2, N3 and extracapsular spread, both of which were statistically significant. 20 of the 114 patients in the therapeutic neck dissection arm, nearly 20%, were unresectable at presentation. We did a Cox proportional hazard model on all factors known to affect outcome in this group of patients. And as you can see, the treatment intervention was highly statistically significant when you put it into a multifactorial model. Other factors known to affect outcome in this group, that is grade, LVE or PNI, and depth of invasion when used as a continuous variable, also had an impact on overall survival. So in conclusion, elective neck dissection improves overall survival by 12.5% and reduces the risk of death by 36%. Elective neck dissection also improves the disease-free survival by 23.6% and reduces the risk of recurrence by 55%. The take-home message for y'all is that elective neck dissection, based on the results of our findings, should be the standard of care there for early stage node negative oral cancers that are operated through the per oral route. One death is prevented for every 8 patients treated with the elective neck dissection. And one recurrence is prevented for every 4 patients treated with the elective neck dissection. So I end with thank you to all my trial fellows and coordinators. This was a long study. The institution for the research grants, all my colleagues on the head and neck department, the artist department that helped me with all the illustrations, but most importantly to my patients and their families. I thank you for your attention, and I'll be happy to take any questions.
Thank you, Neil. That's truly a groundbreaking, paradigm-shifting work. And how in the world did you pull that off?
I'll share with you now. This is off the record. I hope the Stanford cameras, I kind of said that it would.
Can we turn this off? Yeah.
Okay. So when I started my surgical career in head and neck in '84, I realized that Professor Jatin Shah, who comes from India, was in India, and the first slide on his panel on oral cavity is should the neck be treated or not treated. And then he goes on the IFNOS world tours over the years, and they're still asking the same question. And I want to tell the youngsters in this room that we as head and neck surgeons have very few trials. Bevan Yu did a study that a survey that he did, asked by the president of the AHNS, maybe 8 or 10 years back. Bevan would be I still have the slide, I took it from him, and I was telling Ryan this story as we walked up here. He looked at 4 procedures: thyroid, carotid, neck, and laser. Those days, lasers used to be very hot among us head and neck surgeons. All our practices are dictated by B-level evidence and law. So you have a big guy speaking, he's got a loud voice, looks good, everybody follows him. We have no evidence to back any of our surgical treatment, be it robotic, be it laser, whether to operate the neck, whether to do limited neck dissection, whether to do modified versus selective sentinel node biopsy. There's absolutely no level 1. Since we see a large load of oral cavity, we decided, when I took over the department in the early 2000s, I asked some of our staff, each of them should try to lead one trial. So we have this as one. We have another trial that we'll probably come to in a year or 2. We've completed accrual. We are doing the follow-up, cleaning the database. So we should be ready with that 900 patients randomized into 3 arms. It's called the OCAD trial, Oral Cancer Adjuvant Therapy. We look at 5 days a week fractionated radiotherapy, which is conventional. We look at chemoradiotherapy, and then we look at 6 days a week fractionated radiotherapy. Our belief is that if 6 days is as good as 5 days, and if you read literature from Europe, a lot of them give 6 days a week. The Danka group, Denmark, the rationale is, in our kind of setup, if you finish treatment 1 week earlier, patients go back easier, it's cost effective, you get the machine to treat more people, and you avoid the side effects of chemotherapy. So just with this passion that unless you have a randomized trial, no one's going to take note of you, we embarked on this journey. And that's something for all of you all. Please put a question to whatever you'll do. Don't say it because Professor Holsinger told you all to do it. I always tell the youngsters, you have to challenge dogma. You must challenge dogma. There is a trial called the CRASH trial. I don't know if it's not in head and neck. It's looking at the use of corticosteroids in head injuries. Are you familiar with that trial? And for years when I trained, if a guy came in with head injuries, we just shot bolus of steroids till they did this trial and said it is detrimental. I mean, there's so many trials. So you have to challenge dogma. Just don't take it because people tell you to do it. In your own small way. And today's statistics is so good. You can design your studies non-inferiority. You can cut down on the sample size. And very many ways you can do it.
So while you were talking, I was flipping through NCCN guidelines to see about what they talked about in terms of baseline neck imaging. And of course, our guidelines are so useful. They say neck imaging as clinically indicated. So that's where I'm going to open. But I think you said, I didn't notice this weekend, 44% of the patients with elective dissection had positivity in the neck.
No,
No, I'm sorry, 20 some.
29.2,
Right, and then,
close to 30%.
right, and then of those, about 40% had N2 and 3 disease.
No.
Those were therapeutic.
That's for therapeutic, but even in the elective neck dissection, patients did have N2B.
Wow.
They had N2B.
Right, so-
N2B is not more than 3 centimeters. It is multiple.
Right, so that-
22.
So what I'm
That's
getting at,
remarkable.
I assume they weren't the N1s and the N3s, they were mostly just multiple small nodes.
Correct. It could be an occult metastasis in one of the nodes.
Yeah. Tell
So
us a
that's
little
why
bit
the
about
little
the,
asterisks.
how many of those people had ultrasounds at baseline?
Everybody.
Everyone. And this is sort of an open question, is ultrasound, I mean, I think in the US, if people get imaging as clinically indicating, they're putting them into a CT scanner. What are your thoughts on CT versus ultrasound? Because that's going to be one of the things that people say, can we translate this to our experience?
So let me share 2 things with you. When we started this trial in 2004, sonography. It's okay if I sit right.
Oh yeah, please.
Yeah.
Yeah. And I asked him to take his jacket off because it was so hot this morning.
It's so hot in
It
here.
is so
Yeah,
hot.
I don't know what the deal is. Like the AC is off. So
Okay.
please do.
So when we started